Hi everyone, my name is Carla Sterling. I'm a physician at Baystate Medical Center in Springfield, Massachusetts. I did my residency, my medical school and my residency at SUNY Downstate in Brooklyn, New York, and then I did my fellowship for ultrasound at Baystate, and everyone here is so awesome that much like everybody else that comes and does fellowships, I wanted to stay. So I've been here, this is my 4th year here, and I'm going to be talking about emergency biliary ultrasound. Oh, wait, hold on. We got a kitschier title for this year, but I will be talking about point of care biliary ultrasound. This was made by Adam Kellogg, who I'm sure you've been introduced to. So this is a pretty jam-packed lecture. We have a lot of objectives to get through, but we'll get through them all together. We're going to talk about biliary anatomy, which I'm sure you review on a regular basis, but just to dot our I's and cross our T's. We're going to talk about some technical considerations when using ultrasound, which is extremely important no matter what kind of study you're doing. So you can extrapolate that from this lecture to all your other point of care ultrasound. Common presentations of cholelithiasis. Utilizing ultrasounds in the ED workup of, in this particular lecture, right upper quadrant pain. And then, as is always important to address in lectures about ultrasound and techniques in ultrasound, is artifacts that you're going to encounter and pitfalls related. So the question is always, why would we use this? And the answer is because it increases satisfaction for patients because it decreases length of stay in the emergency department and decreases length of time to diagnosis. So patients with uncomplicated biliary colic, you can diagnose them right at the bedside, control their symptoms, and they can leave. They don't have to stay. But for patients who are critically ill and remain undifferentiated, it can be extremely helpful for diagnosis there. Also consider that we are limited by our capabilities and by the machines that we have with us. And so for any technically inadequate images where you don't get excellent views of the gallbladder, and we'll talk about what constitutes excellent views of the gallbladder, or if you find pathology, you may consider getting definitive or more advanced imaging. So essentially what this graph shows is that the majority of biliary ultrasounds that we do at the bedside occur in 10 minutes or less. So that's like nothing in the world of emergency medicine, right? Like we take sips of water that take longer than 10 minutes. So it's a great fast way to diagnose, and it definitely is something that you should practice because the more you practice, the less time it takes. So essentially this says that length of stay is decreased. I said that a couple of slides ago. Emergency physicians, once they have training, are really good at finding gallbladders, and they're really good at finding gallbladder pathology. So in emergency departments where you don't have 24 hours of formal radiology available, it will decrease length of stay. This is kind of an older study, but significantly by minutes, hours, and for patients, that's huge amounts of time. So we're going to talk about using point-of-care ultrasound for diagnosis of gallstones, cholelithiasis, cholecystitis, whether it's acute or chronic, some ways to differentiate causes of jaundice, and then some specific mentions about gallbladder sludge, which is a little bit confusing for people. So technical considerations, we'll talk about the anatomy. There's all kinds of things up in the right upper quadrant. You have solid organs, hollow organs that show up there. We're going to talk about the different vasculature that you're going to see, and also the biliary tract, which is sort of combined in the same anatomical area as the vasculature. And then we're not really going to touch on retroperitoneal or intraperitoneal viscera, but just know that it's there. Right, so we're going to be utilizing the liver as our acoustic window, meaning that we actually want to use this very large, solid, dense, and flexible organ because it transmits ultrasound waves really well. And the gallbladder sits sort of nestled in there, and so we're going to be seeing parts of the liver, mostly the right liver. And then we're going to be seeing the gallbladder. And we're going to be seeing not really the cystic duct. That's only visible if it's very, very dilated, and we usually don't see that. But we will talk about the common bile duct, which you can see often. and then the portal vein and portal triad in general. IVC is not something we're really going to look at when we're talking about biliary ultrasound. But again, it's there. We're going to spend a little time focused on the portal triad, how to identify it, and how to identify pathology related to it. So the gallbladder is usually very easily visualized using point-of-care ultrasound. It's a fluid-filled structure that ultrasound picks up really easily, and it has a 3-layered wall, which normally you won't see unless you're visualizing the gallbladder after somebody eats. So the layers of the gallbladder that you might notice is that the outer layer is very strongly reflective, so it shows up really bright. And then the inner layer is minimally reflective, but it's surrounded by that reflective layer, so it actually shows up pretty dark. And then the anechoic layer in between, which is essentially no echoes. Anechoic means no echoes, so it's black. So the minimally reflective inner layer shows up as like this sort of dark gray. You'll see it in pictures, but really you're looking for the outer layer. We're going to visualize the common bile duct. It runs parallel to the portal vein, often superior to it, so more anterior, so closer to the probe. When you're looking at it on a screen. The internal diameter of the common bile duct is typically less than 4 millimeters. Anything greater than 7 millimeters is considered pathologic, and 1 centimeter is sort of universally considered pathologic. So for preparation, anybody that's getting an outpatient, previously scheduled gallbladder ultrasound, they're going to be told to fast for 6 to 8 hours. But we just do it anyway because that's what we do. So if the gallbladder contracts, it can get really small and it can make it hard to find. So it's a good piece of history to get from your patient prior to trying to do a biliary ultrasound. Also, a really good piece of information to get is whether your patient has ever had their gallbladder taken out. Because I've definitely tried looking for a gallbladder that didn't actually exist anymore. So that's a big time waster, maybe more than 10 minutes for that patient. There are some reasons why a study can be difficult. Definitely body habitus is something that we encounter in the emergency medicine world all the time that makes things hard for us. If somebody has a really small liver, which is also not a typical problem for us, it can make the gallbladder difficult to find. If the gallbladder is very anterior, there's ways to reposition the patient, but that can make it difficult to find too. And excessive bowel gas. We will learn that air is the enemy of ultrasound. It causes all kinds of artifacts that makes our imaging really difficult to see. So that could be a problem. But patient positioning is everything in ultrasound. So if you put your patient in the lateral decubitus position, essentially what happens is it sort of tucks the gallbladder up under the liver. And so since we know that the liver is a good acoustic window, it can make it more easily seen. All right, let's look at some gallbladders and some normal gallbladders. So there's a couple of different ways to locate the gallbladder when you're using ultrasound. This patient that you're seeing on the screen is in a supine position, but again, we talked about the left lateral decubitus position as a good way to position your patients. You can try either way, and you can decide for yourself what you like to do better. Some people like to position the probe so that the probe marker is up facing towards the head of the patient, and then start in the midline and sweep the probe laterally along the rib margin and look for the gallbladder that way. That's not how I do it. How I do it is I plop the probe right down in the mid-lateral clavicular line over the inferior ribs. And for me, approximately 95% of the time, the gallbladder is right there. So try it both ways, see what you like better. In this particular position, you'll be seeing for most patients the longitudinal view of the gallbladder. And this is what it looks like. So you see the liver is here on the left part of the screen. Screen markers on the left side, which is important to start off checking. If you notice that your screen marker is here on the right side, you have to go into your settings of the exam and you have to change it to the abdominal exam, which will then flip it to where it's supposed to be. So gallbladder is here. And then over here, we're seeing the portal triad, which, don't worry, we'll show a lot of images of that. So sweep back and forth for stones. We call this fanning. You want to look for pericholecystic fluid, which would be outside the walls of the gallbladder, between the gallbladder wall and the liver. And then you want to look for the common bile duct. So this is a still image of the portal triad. The portal vein is here, hepatic artery is right here, and then the common bile duct is laying along superior to the portal vein. This is one of several different types of configurations that you can find the common bile duct in. And we're going to show clips of it, so you'll see it in real time. So because the portal vein is a vascular structure, the hepatic artery is a vascular structure, and the common bile duct isn't, if you're not sure what you're looking for, one way to look to be sure about it is to throw some color on it, and whatever doesn't have color running through it is your common bile duct, if you're in the right place. So in this particular image, all of this is very color-filled, and right here is where you're seeing the common bile duct. Right, so that sort of winking thing that's transecting it is the hepatic artery, and then the portal vein is just underneath it. A little more obvious in this slide, this is a still, this is the gallbladder, this is your portal vein, hepatic artery, and this is your common bile duct. This isn't a physics lecture for ultrasound, but I will say that it doesn't matter what color you're seeing, whether it's red or blue, it doesn't necessarily mean that it's an artery or a vein. It actually means it's a physics thing, so it's whatever's coming towards the probe is red and whatever's going away from the probe is blue. So it doesn't, you can't say that's an artery or a vein based on that. And also, as I just discovered from a case in an emergency department, there's a way to flip that so that what's coming towards the probe is blue and what's going away from the probe is red. And it's really hard to change it back if you didn't change it yourself, so be careful of that. Essentially, don't rely on blue and red. Here's another view of the portal triad. Right here is where the common bile duct is. Here is where the portal vein is. So if you're having trouble finding your gallbladder in the sagittal orientation, you can try a coronal orientation. You're still using the gallbladder. Sorry, you're still using the liver as an acoustic window. But essentially, because the liver's so big, you can kind of plop your probe down anywhere, and you'll probably wind up finding the gallbladder, unless, for all the reasons I stated before, you're having trouble finding the gallbladder. So just like everything with ultrasound, you want to look at it in two planes. It's really important so that you don't miss things, and we'll talk about specific reasons why you can miss things if you don't look at it in two planes. So the first is the sagittal view, and then the second, you're going to rotate the probe counterclockwise so that the probe markers pointed towards the patient's right. In this case, it'll more likely be pointing down towards the right side. And this is your transverse view. And this is what the gallbladder looks like in transverse view. It's a little more circular. And this is what is considered the gold standard view for measuring the anterior gallbladder wall. And we'll talk about how to do that in a little bit. Right, so you're rotating, you're starting with the probe marker pointed at the patient's head, you're rotating it counterclockwise. And then again, you're fanning, sweeping up and down, looking for stones, looking for pericholocystic fluid. So when you measure the anterior gallbladder wall, which is this part of the wall up here that touches the liver, you're looking for anything less than 4 millimeters, and that's considered normal. So bigger than that, you start wondering. Here we're seeing the portal triad in a sort of modified transverse view. This is the portal vein. Right up here is the common bile duct. And to be honest, when you look at this image, when I look at this image, I can't tell you what the hepatic artery is. There's nothing staying still long enough for me to see something with an actual pulse. So this one is something that I would throw some color on to be sure. Like I said, there's multiple configurations for the portal triad. So you can have, but always the portal vein is inferior. You can have the common bile duct transected by the hepatic artery. You can have the hepatic artery running over the portal vein. And you can have what's called the Mickey Mouse sign, which when I was learning ultrasound, that's what everybody was talking about. But to be honest, in real life, I've seen it maybe twice. It's just not a common configuration that you're seeing. I think the top configuration is the most common, where you're seeing a very clear transverse of the portal vein and you're seeing the length of the common bile duct running on top of it. Right here we're seeing, this is the clip, this is a still from the clip that we saw a couple slides ago, and then this is color flow on it to show that this is the common bile duct. So in this view, this would be the common bile duct. But again, you would throw color on it. Here is a clip with some color thrown on. This is the top configuration that we saw on that slide. I think the most common, where you have the hepatic artery transecting the common bile duct. All right, let's talk about some pathology that we see. So gallbladder pathology is pretty common. A lot of times people don't have symptoms, but when they do have symptoms, a lot of times they show up in the emergency department. So it's more common in women until people get older, and then the prevalence sort of equalizes. So you're looking for essentially echogenic structures, which means there's going to be bright structures in the midst of this fluid-filled sac that has no echoes inside, so it's all dark, surrounded by a bright wall. Gallbladders have clean margins, and at the very end of the lecture, when I talk about artifacts, we're going to talk about what that means to have something with clean margins versus not. Gallbladders are gravitationally dependent, so if you're not sure if you're looking at a stone versus some kind of polyp or something else, you can actually keep viewing the gallbladder and turn the patient, and they should move with the patient while the patient's turning, also because they're mobile. So these are really tiny, tiny little stones. There's one right here, and then in the transverse view, it's over here. You can see that there's a dark shadow coming out from behind it, and those are the clean shadows that we see. Here's a much larger gallstone with the shadow behind it. And if you notice, and it's important because I'm going to show you some clips of small bowel, which has what we call dirty margins, dirty shadows. And so just notice how linear the shadow margins are. Here's a nice big whopping stone. The shadow is really dark. It has very clear borders. And here's a clip of, well, the cutest group of stones I've ever seen. I don't know if they were cute for the patient, which is why we have images of it, but. Here's a still where there's big stone with some little stones. All kinds of stones. So this is we call this gravel, essentially that the gallbladder is so full of stones, but there's no big stones, so it's just a bunch of gravelly stones. So in this image, we're seeing a lot of different sort of echogenic structures here. I'm going to show a clip of this in just a moment. But this is something that you can't really differentiate without seeing the whole thing, but this was identified as bowel gas. So essentially what you're seeing is two things on this slide. So the bowel gas is over here on the right side, and the gallbladder with a big stone in it is here on the left side. Here, because the image isn't moving, the bowel gas appears to have pretty linear shadows, but when the clip starts rolling, you'll see that that is not the case. And if there's no clip following this, clip's going to be at the end. Right, big gallstone there, some air there. And they look different on clips because they cause different artifacts. That's going to be talked about at the end as well. So here we're seeing some gravel. In the very bottom here, there are some shadows there, but because there's no big stones, they don't cast a really big shadow, but each individual one casts shadows. So you want to carefully fan through the gallbladder looking there. Another clip of clip of gallbladder with some gravel in it. And we're going to be talking about cholecystitis in a little bit. And if you notice, there's some darkness around the gallbladder here. So for this particular gallbladder, it's not simple cholelithiasis, but we see some trappings of cholecystitis. Stones are gravitationally dependent, as was said. So this is a clip of a patient being turned, and you actually watch the stones moving. This is a polyp, and this doesn't move. So as the patient's being turned, this won't go anywhere. So it's a good way to differentiate. The other way you can do it is if you look in two views, you'll notice that the polyps don't move. But they should do that anyway, so you actually want to turn your patient, put them in a different position, and then you'll see that they actually move within the gallbladder itself. Okay. So there is a certain instance when somebody has so many gallstones all stuck in the gallbladder that they have almost complete like obliteration of the actual cystic structure inside, and so it's all just echo filled with stones, and we call it the wall echo sign. And it looks like this. This is something that if you encounter and you're pretty sure it's in the gallbladder, I very much recommend you getting more definitive imaging because you don't want to miss something like abscess of the gallbladder, which can look very similar to this and is a very serious diagnosis that you do not want to miss. So this is a really advanced diagnosis and not something that I would, even myself, I would get a more definitive imaging for this. And just one more clip of this. Right, you can't even see the structure of the gallbladder. It's so full of gallstones. And you wouldn't know this just by looking at it. I know this because this is a clip I know, and I know that it's full of gallstones. In this image, however, the question is this the wall echo sign or is this bowel gas? And I know from looking at it in different planes that this is not. So this is actually bowel gas. And if you notice, there's so much scatter of the ultrasound beams. This is what we call dirty shadowing. There's no definitive lines, there's no definitive border as you move. It's scattered all over the place. Right, so we've talked about the echogenic focus of the stone itself. It causes clean acoustic shadows. They're gravitationally dependent. We saw some images of gravel, which is like a bunch of little stones all stuffed in the gallbladder, and they're all echogenic, so they produce shadows and echoes. We've seen different types of stones, different sizes of stones, and we've seen the wall echo sign. So that's cholelithiasis. Let's talk about cholecystitis. Right, so for most patients, they're going to present with cholecystitis because so many people that have gallbladder pathology don't present until it turns into this. But it's a spectrum, right? So somebody develops gallstones and then they start having pain in the right upper quadrant and then they present to the emergency department for the first time. Some people, however, say, I have a little bit of pain, it's not that bad. And then they start getting much worse pain. Maybe they develop some fever, some vomiting, and then that could turn into cholecystitis. And then that's when we see a lot of patients in the emergency department and when we do a lot of our point of care ultrasound. So signs and symptoms, fevers and chills, right upper quadrant pain. They can have elevation of their white blood cell count. They can have Murphy sign, which is when you press on the right upper quadrant and they inhale and they have pain. And they can even show up with jaundice sometimes if it's progressed to an obstructive process. So the pathophysiology for cholecystitis is that you have a stone in the gallbladder, it lodges in one of the ducts, there's increased intraluminal pressure, right? So the hollow viscus starts to become distended, there's a lot of pain, patients get nauseated, sometimes they have continuous vomiting, and then the gallbladder wall gets thickened or there's edema around it, and they start developing pericholecystic fluid. So there's a lot of complications. None of this is things that you're going to diagnosed using ultrasound, certainly not point of care ultrasound, other than sepsis from cholecystitis. But all of these other things are going to be found on advanced imaging. But just to know that there's a lot of pretty serious complications for cholecystitis, so it's imperative that we find it. Sonographic findings, we sort of went over it when we talked about the spectrum and the pathophysiology, but essentially you're going to see gallbladders with or without sludge. Sludge is not something that you have to see on ultrasound. You do have to see gallbladder wall thickening. Oftentimes you'll see pericholecystic fluid with that. And then a lot of times patients will have a sonographic Murphy sign, which we have actually found out is more sensitive than a regular Murphy sign. And essentially what it is while you're performing the gallbladder ultrasound, you use the probe to push on that right upper quadrant and they have pain exactly where you're pushing over where the gallbladder is. So if patients come in and they look really sick and they have all the findings of acute cholecystitis, but you're not seeing cholelithiasis, consider a diagnosis of acalculous cholecystitis. It tends to occur in the very sick or in people who were discharged or just very sick, major trauma cases, major burn cases, patients that had a prolonged stay in the ICU. It's a really serious diagnosis. It can cause sepsis just like anything else, even though they don't have stones. So it's important to find. So, as I said before, anterior wall thickness should be less than 4 centimeters. Anything greater than that is considered abnormal. Other processes can cause thickness of the wall. So postprandial contraction can make a wall look thick, but when you actually measure it, it's a normal thickness. Anything that causes ascites or fluid buildup in the body can cause edema of the gallbladder wall. Consider that if you're not finding gallstones or other signs of cholecystitis. So you're measuring the gallbladder wall here at the most anterior part. This, you could even go higher than this, but anything along this wall is fine, right where it touches the liver. You're measuring from the most outside part of the wall to the most inside part of the wall, but only in the anterior wall, right? So it's really hard to see because this is a normal gallbladder wall thickness, but this is going from the outer wall to the inner wall. In this case, you have a still gallbladder that has a thickened wall. You have some pericholecystic fluid around it, but this is the outer wall and this is the inner wall, and you can see at 0.63 centimeters, it's thickened. Here's another example of a thickened gallbladder wall. This one's pretty thickened. Here you can actually see a lot of other pathology, right? You can see some sludge, you can see some pericholecystic fluid, and you see the gallbladder wall thickening. This is a clip of that same patient, of the still we just saw. This is a really bad case, right? You have sludge in there, you have tons of gallstones, the wall is really thickened, and there's so much fluid around it that the wall almost looks like ratty and jagged. This is the sagittal view, and this is the transverse view of the same case. Pretty clear evidence of cholecystitis in this case. This patient was so obtunded that there was no sonographic Murphy sign because they were really unresponsive, they were really sick. This is a case of gallbladder wall that is definitely thickened, but you can see ascites all throughout the peritoneal cavity here. So this is ascites, and ascites caused by whatever causes ascites, right? So you can see this in heart failure patients, liver failure patients. That's sort of a non-specific cause of gallbladder wall thickening. So look for ascites. And these are examples of postprandial gallbladder wall. So what happens is that the gallbladder contracts. And what's interesting is that when you see a normal gallbladder that isn't postprandial, the wall is very thin. And when you see an abnormal gallbladder wall, because of cholecystitis or other pathology, it's thick, but it's sort of this homogeneous grayscale thickness. When you have postprandial contraction, where the wall looks thickened, you're actually going to see, this is the only time you're really going to see all the different layers of the gallbladder wall. So it's another clue that this is non-pathologic, but you do want to measure it. And when you measure it, it actually tends to look totally normal, tends to be totally normal. But it also makes it hard to find. So the sonographic Murphy sign is a pretty sensitive indicator. Again, you place the probe while you're doing the gallbladder ultrasound in the right upper quadrant. You have the patient take an inhalation if they can do that, and they have pain when they inhale, and it causes like breath hitching, and that's a positive sign. So the occurrence of pericholecystic fluid is just weeping of serous fluid from the surface of the gallbladder as it gets edematous. It can represent impending terribleness for your patient, so it's something to be taken seriously. These patients basically need to be treated like pretty severe sepsis right away. So you want to give them antibiotics, you want to give them fluid resuscitation, and you want to get a surgical consultation as quickly as possible. This is a clip from the same patient that we saw some clips before. The clips we saw before were fanning all the way through the gallbladder in 2 different views, which you really need to do. But this clip is sort of an abbreviated clip because I really wanted to show the pericholecystic fluid here. Close up, pericholecystic fluid. You actually see 2 views in one in this one. So in cholecystitis, you can have an enlarged common bile duct. It can be difficult at first, but it's definitely worth practicing because it's important to know, because you can actually have normal gallbladder findings and you can have enlarged common bile ducts, which is indicative of obstruction that doesn't have cholecystitis. So it's worth it to practice. Again, left lateral decubitus position, and you're going to be looking for the common bile duct in the sagittal view. So we talked about measuring the anterior gallbladder wall from the outer wall to the inner wall. For the common bile duct, you're going to be measuring the internal diameter of the duct itself. So it's really just where the walls, the space between the walls. Anything normal is basically 6 centimeters or less. Pathologic is considered greater than 7, but anything greater than 1 centimeter is considered definitively pathologic, because as we get older with each decade, your common bile duct can increase by 1 millimeter. So if you're 80, it could be 8 millimeters, and that's normal, and so on. This is a still with a pretty dilated CBD. Essentially, if when you're looking at the common bile duct, it's approximately the same diameter as the portal vein, you can bet that it's pathologic. If you're a bettor. I'm not a bettor. I just know. Right, so this is another one where you're seeing an enlarged common bile duct. It's pretty much the same size as the portal vein. And here we're seeing that pretty normal configuration where the hepatic artery is here, the portal vein is here, and common bile duct is running right superior to the portal vein. And here what we're seeing is an enlarged common bile duct right on top of the portal vein, and if you notice at the beginning of the clip, you're seeing a gallbladder stone sort of lodged down towards the neck of the gallbladder, which is presumably causing the obstruction unless there's another stone lodged somewhere. So, gallbladder sludge. We see it sometimes, we don't see it other times. It's hard to know what it means. What do we do with it? Essentially, don't worry about it too much. It's something to be followed up on if you're not seeing anything else, right? No gallstones, no pericholecystic fluid, they don't have a sonographic Murphy sign, but it can be associated with some other intra-abdominal pathology. So consider that it's there and that it may mean something, but in and of itself, you can't really take anything away from it. It's found in approximately 2% of right upper quadrant ultrasounds. Anecdotally for myself, I have not found that to be true. I would say for me more like 1%, but that's just me. A lot of times it'll resolve spontaneously, so again, this is something to be followed up as an outpatient unless it's found with other pathology. So if you find it in the presence of gallbladder wall thickening, pericholecystic fluid, sonographic Murphy sign, you're thinking, even if you don't see an obvious stone, that this is cholecystitis. It's low amplitude intraluminal echo, and essentially what that means is it shows up as like a darkish gray. It definitely exhibits dependency, and this is relevant because there are some ultrasound artifacts that can sort of mask themselves as sludge. We'll get to that later. Here you're seeing a still of sludge. It is here layered at the bottom of the gallbladder. Here is sludge. Same patient, transverse view. If you look carefully at this, you'll notice that there are some very bright spots that show themselves as you're fanning through the gallbladder. At the beginning of the clip, there's one right here. At the end of the clip, when we turn to the sagittal view, there's one that shows up right here. There's one, there's one. Right, so little tiny stones inside. This is a much larger stone inside the sludge. In rare cases, and this is why I suggest that if you're seeing what you might think is a wall echo sign, which is when, if we go back several slides, when the gallbladder is so full of gallstones that you don't really see a normal gallbladder, you definitely want to get more definitive imaging, because this is 2 views of a patient that had a very large gallbladder abscess, and you wouldn't really know, right? Like, this looks totally abnormal. It doesn't really look like gallstones. So if I'm seeing this, I know I'm going forward to get more definitive imaging, because it looks abnormal and it doesn't look like normal gallstones. Here what you're seeing is a large gallbladder that looks full of all kinds of garbage, and then you see a giant stone here at the bottom. right? So this was a patient, and you see pericholecystic fluid. So this is a patient that had acute cholecystitis, probably waited a little too long for some medical attention, and the gallbladder turned into a large pus-filled structure. This was a patient that had acute cholecystitis that waited so long that actually all of this garbage around it, it's so murky, and I don't think this looks like a normal shaped gallbladder, right? So this was actually a patient that wound up having a perforated cholecystitis. Look at the common bile duct over here, it is super large. So back to acalculous cholecystitis, it's a very serious but not often seen entity in emergency medicine. So you're looking for all the trappings of acute cholecystitis, but you won't see any gallstones. Maybe sludge, maybe not. These are patients that need antibiotics, broad spectrum antibiotics, and surgical consultation. As I said, it's frequently a complication of polytrauma, extensive burns, prolonged ICU stay. It's something to think about, because if you don't think about it, you may miss it. It's easy to miss because we don't see it very often. This is an example of, you don't have that much of a thickened gallbladder wall, but you definitely have pericholecystic fluid. The size of the gallbladder doesn't really matter. Probably this patient was so sick they haven't eaten very much. But you have a very enlarged common bile duct over here. You have pericholecystic fluid. Probably this patient was very, very sick when they arrived. And very, very, very enlarged common bile duct here. And then with color on it confirmed. So we're gonna just touch on jaundice. We're not gonna spend a lot of time on jaundice. Point of care ultrasound can be useful in diagnosing obstructive versus non-obstructive jaundice, and that's pretty much it. That's the whole clinical utility of using bedside ultrasound. And the reason is because somebody comes in with painless jaundice, if they have a very enlarged common bile duct, then you know that they have an obstructive process, and that can sort of help with expert consultation and clinical course. But beyond that, you're not really going to find any causes for it using ultrasound. It's just to know whether or not the patient has an enlarged common bile duct indicative of obstruction. But it doesn't tell you why, right? Because this patient had a CT scan done and it showed a very large pancreatic mass, which is why they were obstructed. It wasn't because of a stone. Gallbladder cancer is something to mention, but it's definitively outside the scope of point of care ultrasound. You may find incidental things that could lead you to think that you were looking at a patient that had gallbladder cancer, but this is not something that we would diagnose at the bedside. It's still pretty rare, even though it's the most common biliary tract malignancy. Patients that have it typically have a history of gallstones. Ultrasound is not the definitive diagnosis. You're going to be getting CTs or more advanced imaging as an inpatient with MRI. So you may see a mass, you may more likely see some kind of a polyp or a fungating intraluminal mass that doesn't follow the laws of gravity and doesn't really look like a stone, and doesn't really look like sludge because it doesn't have shadows. You can see wall thickening, and you can sometimes see direct invasion, but essentially that would look like just something abnormal off to the side of the gallbladder. This is an example of a polyp found with some kind of a mass attached to the wall. But if you look carefully behind it, there's no shadow. And so that tells you this is not a stone. This is a case caught of porcelain gallbladder. Again, this is something that you would look at and you would say, I don't know if this is a wall echo sign. I don't know if this is, well, you would be able to determine whether it was small bowel because you're practicing and you know how to do that now. But it would be really hard to decide whether this was just full of stones or one big giant stone, so you would get advanced imaging for this. So let's talk about some pitfalls. This is where we talk about artifacts, which are really important when you're doing point of care ultrasound. So common errors that I have seen is that if you don't visualize the entire gallbladder, and that includes looking at it completely in the sagittal view and completely in the transverse view, And the way you visualize it is you move the probe up and down so that the gallbladder completely goes away, and then completely comes back into view, and then completely goes away. And that's how you make sure you don't miss anything. If you overread the artifacts that we're going to talk about, and you misinterpret shadows as stones, it's a common error. And then really, if we don't see the images that we need to see, if we don't get the proper view of the gallbladder, we can't really say anything about it. So you can't infer things that you're not actually seeing. So we talked about stone versus bowel gas. This is a really important one because the small bowel lays right next to the liver, so you will often see small bowel when you're doing gallbladder ultrasounds. Right, so the gallstones create clean shadow margins, and air does not, right? So you can't see it in the still, but when you look at the clips you can. And there's reasons for this. So what a stone actually does is it reflects ultrasound waves back to the probe. And so everything behind it is dark because you have ultrasound waves coming out to the sides of the stone, and that's continuing on, so you're seeing everything on the sides of the stone, but all the ultrasound beams that hit the stone get reflected back up to the probe, and so everything behind the stone looks dark. With bowel gas, what happens is that the ultrasound waves hit gas, and gas scatters all the waves everywhere. So you get this sort of scattered view of everything, which is why there's no clean definitive margin. Because you're not reliably seeing things on either side of the bowel gas because scattered ultrasound waves are going everywhere. Right, it's clearly clean border. The other thing you want to make sure is that whatever you're seeing is inside the gallbladder. And the way to do that is to, well, first of all, it's interesting because you can actually see peristalsis if you stop moving your probe and just look at the bowel. Gallstones don't peristalse. But that's why we look in two views, right? Because then you're sure you're seeing it inside the gallbladder. Polyps are adherent to the gallbladder wall, whereas gallstones will move as you move the patient. Here we're seeing stone, and stone moves as patient moves. Here we're seeing polyp, two little polyps. It's hard to know that the patient's being moved because they're not moving. The patient's being moved and they're not moving. Another example of a polyp scene. Stones in the gallbladder neck can be really easy to miss. Either you're not looking for them, or they're really small, or there's a rib shadow. All kinds of possibilities for why you might not see them, but just look carefully because this patient's gallbladder wall is thickened. In some views, it looks like they have pericholecystic fluid, and so should you miss these stones in the gallbladder neck, then you might miss that. Right, you might treat that for Acalculous Cholecystitis, you may get more definitive imaging, but if you find it, just look a little harder. You have your diagnosis. They may be hard to see. This one I think is actually, this one's pretty easy to see, but as the clip goes on, you'll see a couple more stones here that I think would be potentially easily missed. And the reason is because, well, another reason is because you have another artifact called edge artifact. And this is a refractory artifact. And it causes shadows to happen at the edges of the gallbladder that might confuse you in the beginning to look like stones. And the reason is because ultrasound waves will hit the side of a round structure and then be refracted. So since nothing's going behind that, that area is dark. And it looks like this, right? So this is edge artifact. Ways to make sure that you're seeing edge artifact instead of a stone is to, again, look at the gallbladder in the other view, right? Rotate 90 degrees. And you'll see edge artifact in that view as well, but you won't see a stone, which in this case, if you turn it 90 degrees, would be in the center of the gallbladder. So that's how you make sure you're seeing artifact and not stone. Another thing that we encounter for a lot of different types of ultrasound studies that we do in the emergency department is something called posterior acoustic enhancement. And it happens because the structures that ultrasound waves hit as they go reflect, absorb, refract, whatever the ultrasound waves in different ways because of their densities and their structures. And so a fluid-filled structure where it's just fluid on the inside transmits ultrasound really well, and it doesn't attenuate the ultrasound beams very much. And so it goes straight through down to the bottom of that structure, and it's really, really bright still. Whereas everything on the other sides of that structure has attenuation, so when it gets to that point, it'll be a little bit darker. So at the back of a fluid-filled structure like the gallbladder, like the bladder, like the eyeball, you'll see a very bright structure, and it can actually cause false thickening of that wall, which is why we only measure the anterior wall of the gallbladder, because you could get false thickening if you measure the back of it because of posterior acoustic enhancement. This is my favorite ultrasound artifact, and it's because it's a really weird explanation for it. So in a fluid-filled round structure, ultrasound beams are hitting the back wall at all different angles, which means that if they are refracted or reflected, they bounce in all different angles back. So some hit the probe at really weird angles. And it can cause an artifact called side lobe. And sometimes in the gallbladder, it can be misconstrued as sludge. In the eyeball, it can be misconstrued as vitreous hemorrhage. So this is what it looks like. How do you know that it's not sludge? Number one, it crosses the wall. In all these places, it crosses the wall. Sludge isn't going to do that. Number two is when you look at the other view, it's going to look the same, but it won't be dependently in the same position as it should be when you're looking at the gallbladder in that view. It was explained to me in this really great way, so I'm going to explain it to you the same way, which is essentially that if you have you're having a conversation with one person. If there's a bunch of conversations happening around you, the majority of what you hear is going to be that one person. But some of the snippets of the other stuff is going to come in, and it might even distract you a little bit. And essentially that's what side lobe artifact is. So you just have to do all the things that you would do otherwise to confirm gallstones, confirm pathology, and you'll know whether or not you're looking at side lobe. So it's not dependent. Physics-wise, it doesn't make any sense. So it's a good clue that it's not real pathology. So this is real sludge. And this is real sludge with stone in it, as opposed to this, which is side lobe artifact. Okay. So let's run through some cases really fast. 27-year-old female presents at 4 a.m. She's got nausea, she's got vomiting, abdominal pain. It's been going on for a few hours. Pain is sharp, intermittent, past history, unremarkable. Everything about her is normal except her right upper quadrant exam, right? She's got some tenderness there. Pelvic exam is normal. So because you're good at point of care ultrasound and you know that it's useful and can help with diagnosis, you look and you see that she has gallstones, but she doesn't have any evidence of cholecystitis. Right, common bile duct normal in size, anterior gallbladder wall is normal, no pericholecystic fluid. So lab evaluation's normal, you give her some symptomatic treatment, she feels great, and you say, great, you go home, follow up with surgery. On the other hand, you have this elderly woman sent from a nursing home for altered mental status and fever. She is very septic appearing, both in her presentation visibly as well as her vital signs. She doesn't really talk to you, but she winces with right upper quadrant palpation. So you throw the probe down, and this is what you see. Okay, so we saw this clip earlier in the lecture. It's clearly cholecystitis. Right, so she has acute cholecystitis, antibiotics is started, surgery is consulted, all of the things fit. She's got a leukocytosis, liver function enzymes are elevated, and because she was so sick, CT scan was done and shows some real significant pathology that shows maybe it perforated. So you did her a service by doing a bedside ultrasound, which started her treatment really early and got expert consultation on board really early on in her course. So you did a lot for this patient by doing point of care ultrasound. So some final thoughts. You do have to understand the anatomy in order to know what you're looking at. You have to practice. You have to position the patient for your best images. You can start with them flat, then you can turn them on their left side. Understand the difference between pathology and artifact, and that really just takes practice. Stones can look different in different places. They can be difficult to find, like in the neck of the gallbladder, so look carefully. Understand the different findings of cholecystitis. Know your limitations. Know when to get advanced imaging. And again, you gotta practice. You won't learn anything about ultrasound without practice, practice, practice. You gotta do it all the time. So that's the end of the lecture. Does anybody have any questions?
Dr. Sterling, thank you so much for that comprehensive review of all things gallbladder ultrasound. I just had a quick question about, if it's okay with you, about that last case you mentioned. And I think you might have addressed it earlier, I just wanted to clarify. Showing the elderly woman with the obvious pathology in her gallbladder. So that's a patient you would still get a CAT scan on, even though you feel like you found the answer to what her source of sepsis and illness is coming from.
So in this, I put this clip back up to explain it. So in this particular patient, the area around the gallbladder is so edematous and so, like, you know, we all use our special little words that we have as emergency physicians. So I'm gonna say ratty. It just looks so awful that I would be concerned that we missed something like a gallbladder perforation. So in the beginning, when you're learning how to do a point of care ultrasound and you're doing gallbladder ultrasound, if you find cholecystitis and it looks like minimal amounts of pericholecystic fluid and the patient's maybe not super sick and septic, I would say it's okay to like say, this is what I found, show your surgeons the images. They may want something else. If they're the expert consultation, do what they want. But in a patient that comes in like this, that's so sick, and their findings on point of care ultrasound are so bad, I would be worried that I missed something like a perforation.
Thank you, that's great.
Yeah.